So, hello everybody. Welcome to the 5th edition of our EEG curriculum here at the Book Zurich, and I welcome you to this day's event, which will focus on ECT and EEG in epilepsy. So the main objective for today's meeting is to recognize epileptic patterns in the EEG, which is one of the main tasks we have to carry out when looking at EEG. And the second big objective of this day's meeting is to understand EEG's use in electroconvulsive therapy, the ECT, for example, for seizure threshold assessment and assessment of the duration of the seizure. And in the end, hopefully, we'll find time to have another EEG case report, and let's see how far we can get. So let's start with a few hints. So again, this is the QR code for our quiz. I want to thank again Tobias Welt for providing this, and I hope you all have a look into the quiz because it resembles most of the information we carry together here during the curriculum, but also there are some questions that maybe go beyond the horizon of this day's meeting. However, I think all of these questions are solvable with one or two looks into a book. Or maybe even with your knowledge. So use it, and the 5th session now is available from today on, and I think Tobias will also share the link again in the chat. Second tip I have for you is the stream of the so far carried out curricula we've done here on Monday mornings. So you will find them on YouTube following the given link, so that you can rewatch what we just recorded here and what you just heard here, and we will add all the other recordings when they have been done. And last but not least, for today, I got a tip for you regarding the book. It's called Reading EEGs and a Practical Approach. It's the 2nd edition by John Greenfield, James Geyer, and Paul Carney. I have to admit that for this day's meeting, I took most of the examples from this book, and this is due to the fact that in psychiatry, we of course see often spikes and spike wave complexes, so epileptic-like activity and interactive epileptic activity. However, we don't see them in so highly frequent that I could take the examples from our database, so I took them from the book so that you can see what you should look out for. So everyone who's interested, this book is a good recommendation. All right, so for today, we're gonna see a lot of EEGs and patterns that we have to or try to identify in the EEGs when we see them. To identify epileptic form activity in the EEG is, as I said, one of the main tasks, because most of the EEGs are done to exclude those epileptiform activities. That means for many patients and for many patients that have been administered to our clinics, we have to rule out that there are any organic causes for their psychiatric syndromes. And often epileptic seizures could mimic in parts the psychopathological findings we have in those patients. So ruling out these signs is very important. Let's start with the first example. This is the sharp vertex waves in this EEG, and I marked them for you. And this is an example from a 7-year-old child. Okay, we don't see too often 7-year-old childs, but as it is very important, it's good to figure out how those patterns look like, because the patterns themselves are similar in adults or in infants. So it's good to be aware. And what you see is the sharp waves localized mainly, as you can see when you look at the montages, in frontal central leads, equally distributed over the frontal mid-cortex. And these sharp waves are clearly identified as and this is a very important feature of epileptic form activity, they stand out against the background activity. So you see the background activity before and afterwards, and you clearly see that those sharp vertex waves stand out. The name vertex waves also indicates where you can find them, and this is the vertex. So this is the highest point when you are standing tall, and this is the point where you measure the height. So this is the vertex, and there's where you find and those patterns in its highest amplitude, regardless which one that you choose. So let's continue to the next one. And what is important is that there are some kind of epileptiform activities which are not clearly indicative of some epilepsy. So they are called the benign variants. That means you can find those patterns, but there are not necessarily in pictures of an epilepsy going on. And here's the first example. It's called lambda waves, occipital lambda waves, and you can find them over here. So this is, oh, sorry, the red circle is a little bit wrong. So you can see here at the temporal occipital leads, you see those lambda waves. And you can see those waves when someone, for example, is focusing something with his eyes and reading. And this reading saccades sometimes show in the EEG like those lambda waves. They are not from the eyes, but they are generated, of course, from the cortex. What else can you see in this EEG picture? What you see, this large artifact over here, of course, and this is an eye blink. So the person is then closing its eyes. And after the eye blink, you see clear, very fast alpha activity. So it's a little bit faster than alpha, and this is the so-called alpha squeeze effect. That means someone closes his eyes and the alpha rhythm is or speeds up a little bit. So this is faster than the normal individual alpha rhythm. However, there are the lambda waves, there's the artifact, and then there is this alpha activity going on. So these lambda waves are not pathological. Again, we have some called benign epileptiform discharges. So it's called BETs. And they very often occur when you are drowsy. That means when you just had a sleep-deprived patient, or if someone was up for a long time or could not sleep, had sleep disturbances, then you can see those BETs. And what you see here is a clear spikes, as you can see them here, distributed mainly over the frontal left electrodes. You see here F3, F3, C3, but also spreading toward the right occipital cortex. And what is clear is that there is a shift of the direction it's going. So it's got surface negativity here in FP1 to F3, and it's got positivity over P3O1. So this is a spike, but it occurs quite often when you're very drowsy. There's the next one that's called epileptiform activity called wicked spikes. And this is also common during drowsiness. And this pattern, these wicked spikes, they resemble a pattern of 6 to 11 hertz, so theta alpha range. And you see them here over the temporal cortex on the left side, spreading out to the occipital cortex. And you see here, this is 1 second. It's not very clear for you maybe, but this is a second. So you see it's 1, 2, 3, 4, 5, 6 hertz. So it's in the theta range. And this is not alpha activity, of course it's too slow. And the shape is a little bit different than a clear alpha activity. So this is a so-called wicked rhythm that you can see, and it's related to theta activity. So you learn now that there are some patterns that can occur mainly during either you're very young or you're drowsy, and then these patterns can occur, and they do not necessarily indicate that there is an epilepsy going on. So if we look at the numbers, we know that 12 to 50% of EEGs show interictal epileptiform activity, IEA, after a seizure. Highest amount within 24 hours after a seizure. So if you have a patient on the ward that has a seizure or is suspect to have a seizure, then you can do an EEG, and there's a high likelihood that then you can see some epileptiform interictal activity. And this is maybe not a proof, but it points toward the direction that a seizure is very high likely. And if you make more than one recording, so let's say 3 recordings, we don't have the capacity often, but if you can do that, you will have up to 84% security that you will have an IEA in your EEG recording. However, 0.5 to 2% of the individuals which show IEAs have no seizures. So that means 2 points, and we have to remember that on the long shot. So if there is an interictal epileptiform activity, it is not an absolute evidence that there was a seizure. Okay, so it's very clear, as we saw, that there are some spikes that you could have, without having seizures. However, if there is not an interictal epileptiform activity, as we see on the first point, this is not an absolute evidence that the people has epilepsy, that the people do not have epilepsy. So you have to consider this into both directions. If you have interictal epileptiform activity and it correlates with the clinics, you've got to do something about it. However, if you don't find anything in the EEG, that doesn't mean that there is nothing. So let's get to the real epileptiform activity in the EEG. And as I said, these examples are taken from this textbook I just showed you in the beginning. And one of the most important things we have to consider, especially in psychiatry, maybe it's not the myoclonic or tonic seizures, because we can identify them clinically, but it's the so-called absence epilepsies. That means the patients just lose their consciousness in some way. They keep standing, but however, they just lose their consciousness for several seconds, the so-called absence, and it's a partial seizure going on in the brain, in these regions of the brain that are responsible for your consciousness. So these absence epilepsies often mimic psychiatric problems, like loss of concentration, problems with attending school, or problems in the job, and so on. And what you can see in the EEG is the following. As you can see here, this is a clear epileptic activity. So this is not an interictal activity itself, because you see the highly synchronous activity spreading over large regions of the brain. However, you can see, for example, in the T3, T5, the activity is not that pronounced. So there's almost normal activity, only later it gets onto that activity. And also at the T4, T6, the activity of the seizure is not that active. That means it's not a generalized seizure, but it's only is going on in some parts of the brain. However, if you can imagine that this activity is going on in the brain, and this is roughly a 3 to 4 hertz activity here. If this activity is going on in the brain, of course, the brain is not ready for any other activity. So, of course, you lose your consciousness, and this is highly problematic in these individuals. Sometimes you can see those kind of trains, these kind of hypersynchronous EEG trains with high amplitude, not only during the seizure itself, but sometimes they have it also as some kind of interactive activity without losing the consciousness, for example. So this can also be a sign that something is wrong, even if the patient acts normal. This example here is taken under so-called photic stimulation. We had this before. So sometimes, or not sometimes, if you record an EEG, also at the book, the people are forced to look into some kind of strobe light that occurs at a certain frequency. They can close their eyes. However, the light is very bright, and this evokes activity in the brain, a synchronous activity in the brain, and this also can evoke seizures if the subjects are prone to that. So this is some kind of stimulation method we use to evoke epileptiform activity or even seizures. The next example is the second most often occurring, or the most often occurring generalized idiopathic epilepsy, and it's the myoclonic epilepsy. And this is in comparison to the absences, it's the seizures where we have this motoric reaction in epilepsy. And what you can see over here are clear spike wave complexes occurring. And what is very nice in this example, you can see as it stands off the background activity. And this is very important for all kinds of epileptic activity. It has to stand off the background. So you see here over the occipital cortex, the clear alpha activity going on. And then suddenly those spikes kick in, and these large amplitude 3 to 4 hertz spike wave complexes come with the slow waves following after. So this is a clear sign of an epileptic activity. This example has been taken from a, I think, 15-year-old person, and the example is written in the book I just showed you. Now we get to different parts of the brain, so I don't want to show you too many syndromes because this is very difficult and we need neurologists to be clear about that. However, it's good to see that something is wrong in the EEG, and what is important is that the signs in the EEG often look the same, and we describe the epilepsy very often regarding or considering the parts of the brain where we see the epileptiform activity. For example, here we have so-called right frontal epilepsy or frontal lobe epilepsy. And as you can see, the spikes over here, they occur at the FP2, F8, with its highest amplitude. That means they are at the right frontal cortex. And we also see that in the rest of the EEG, the other electrodes don't show these signs. So this is a very localized spike, and this is a sign of a frontal lobe epilepsy with a focus at the right frontal cortex. And we also see that, very interesting, that we have a slowing accompanying these spikes, and these slowings are in other areas of the brain. As you can see here, this is a delta, maybe even a delta wave, and going on in the left temporoparietal cortex and also in the right cortex. So this is a sign for frontal lobe epilepsy. And if you now go to a frontal seizure, so this was the interictal activity. So the patient is normal, you don't see a sign of a seizure, but you have those signs in the EEG and that show that there might be an epilepsy going on. And then we have, of course, the seizures themselves. And what you can see over here is a frontal seizure, so a frontal lobe epilepsy with the spikes in the interictal EEG. Then shows, if you have long-term recordings and you record a seizure, you can see the EEG over here, and you see in the frontal electrodes, again, FP1 against FP2. So frontal electrodes, they show at first those spikes and then the slow activity, and then evolving into a rhythmic activity that spreads out over the whole frontal cortex. And this shows it's partial seizure going on in this EEG. So next thing, epileptiform activity in the temporal lobe. So now things repeat. So now we have those spikes, so the interictal activity not in frontal areas, but in temporal areas. And you see over here the spikes at F7, T3, and the highest is at T1 against the reference, and you see the highest spike. And it's not an artifact because it spreads out over many electrodes and also different montages. And this is a clear temporal spike, which could be a sign for temporal lobe epilepsy. And again, if you look at temporal lobe seizure, so again, this is not interictal, this is the ictal activity. You see that here with the highest amplitudes at the T1, so the left electrode, left temporal electrode, the highest amplitude, the seizure is going on, clearly showing seizure activity in this area of the brain. There are some other discharges, periodic lateralized discharges. They change name every 5 years, so don't worry, but sometimes, so it's like discharges that show no normal activity. And I just put you some examples here in the 82-year-old male with some organic problems in the brain. And you see here widespread those discharges. Clearly, this is not normal activity. Sometimes it looks like a spike, however, going into some kind of rhythmic activity and clearly no physiological EEG. And maybe one last example, I said I won't show you too many syndromes. However, I show you one syndrome because this might be relevant in psychiatry. It's the Creutzfeldt-Jakob disease. It's an entity where people degrade cognitively very fast based on the prion disorder. And this sometimes resembles the picture we see in fast evolving dementia. So an EEG here could help because Creutzfeldt-Jakob disease had this typical triphasic frontal waves. And you see the triphasic 1, 2, 3, those large triphasic delta and theta activity in the brain, high amplitude. And this is very sensitive for Creutzfeldt-Jakob disease. However, it is highly specific for Creutzfeldt-Jakob, but it's not too sensitive. That means if you see those patterns, you can be sure, most likely be sure that this could be Creutzfeldt-Jakob. If you don't see the patterns, however, it still could be that they have it. So again, the EEG is sensitive, but not sometimes very specific. And in that case, it's the other way around. So again, here for you to understand the triphasic waves, take it from another publication. So this is A, B, C. This is the triphases of these waves pathognomologically for Creutzfeldt-Jakob disease. So time is running, 10 minutes left. So just let's jump into the EEG and electroconvulsive therapy. What do we need that for and why do we need it? The problem is that in ECT, we need a seizure that should last at least 25 to 30 seconds. The duration of the seizure beyond that has been proven not to be clinically efficient. So that means we need our patients to have a seizure for that period of time. If we don't reach that, we have to change something in the parameters, have to set more energy, or have to reset the places where we stimulate. And to control for the duration of the seizure, one could do two things. One thing is we could visually control for the seizures. However, the patients are relaxed, so you won't see the tonic-clonic activity. In some centers, they just bend off one arm and don't get the relaxant into this arm, and you see the seizure then at least in one arm. However, this is not very sufficient to monitor the seizure activity. So what we do is we record the EEG here in our center at two electrodes, two frontal electrodes. You can see it here, the bifrontal electrodes. So we don't only stimulate there, but we also record the EEG. And what you then see in the EEG is only a bipolar recording, as you can see it here, and you see a clear hypersynchronous high amplitude activity going on, clearly indicating that there is a seizure. And then you got the post-ictal suppression. That means after a seizure, very often the EEG turns out to be kind of flat. So this is where you can see where it is terminated. And you see here after 1 minute and 18 seconds, it's terminated. The good thing is the EEG recording device will only start that after you press the button and give the energy. So the seizure onset is terminated, and you have to look after how long it went on. We see some more examples here. We see the baseline EEG on top. So a lot of artifacts. However, you see this is not hypersynchronized. Although you see some kind of delta activity going on, this is a normal background activity of a badly applied EEG. Let's be clear, but this is reality. And on the bottom, you see the clear hypersynchronous activity that marks the seizure that we need in ECT. All right. So let's again look at the quiz you can do and try to solve all the questions Tobias put aside for this day's talk. And to use the last minutes we have together, I'm gonna open some EEGs. Let's see if we see something. And I have to excuse myself because due to some changes in the IT, I was not be able to access the database I had. And I just found these two EEGs. And to be clear, they are not pathological EEGs, but they are normal EEGs we see in psychiatry. So I just want to guide you through that. But maybe before we start, are there any questions on the slide I just showed you? So you can also take your time and we start to look at the EEG. Okay. So for all of you that haven't read an EEG before, we start always, maybe boring for some of you because you already know it, but good for the others. So we start with the EEG in the beginning, and we again check what kind of voltage do we have. So here we have the average voltage, every electrode against the average of all the other electrodes. We first check the ground rhythm. I've just marked you 1 second, and we can just count, take the positive flexions going down. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 to 11. So 10 to 11 hertz seems to be the prevalent rhythm. So this is the basic rhythm as you look at an EEG. And in the ECG for the heart rate, you look in the basic rhythm for the brain, and we go through that. And what we also see is we try to check the notions that the assistants gave us. So here everything seems to be good. No epileptic form activity detected from them. However, we go through. We also check if the ECG down there is rhythmic or if there are any ventricular extrasystoles or anything else going on. It also looks like we have a P wave just for checking. And then we go through the EEG. And as you see, although we have some clear alpha activity at occipital lobes, we also see that there is some kind of background slower activity going on, especially here in the left occipital regions, and we try if this will evolve toward some kind of slowing. And we see, yes, here at the occipital lobes and also on the left occipital lobes, there is slow activity going on, some slow delta theta waves. So this looks like there is some, not generalized, but some focal slowing in this EEG. However, this is nothing specific. This could be anything, and we will see if this will get larger or not. And we also recognize that slowly the vigilance is going down. We see that the alpha waves that we see every now and then is going down. Here and that part to totally desynchronized EEG, a flat EEG. So this person slowly drifts towards sleep. And as we can see, it opens the eyes again and closes the eyes. And we see that the Berger effect, so the occurrence of alpha waves is fine. So this person has a good reaction on closing the eyes and also opening the eyes here, closed eyes, eyes open, and the alpha rhythm just vanishes. So the EEG alpha effect is very nice. So that seems the vigilance for that part seems okay. And then we continue a little bit faster. To say you see the slight slowing, and you see also the slowing getting a little bit larger. However, it's not very clear if this is really a slowing or a decrease of vigilance. And so we'll keep an eye on that. See some larger waves. This is not a spike because it's not standing out of the background activity too much. So we can continue with that. So, and we come here to the so-called hyperventilation. So this is the next procedure we do to evoke some pathological activity. And you do this to evoke or to stress the brain so that potential, let's say, potential parts of the brain that do not work at its best will show their deficiency. And what we see over here is during the hyperventilation, this slowing that we saw before is slightly increasing. Okay, this is not very pronounced, but we see that alpha hyperventilation in the occipital cortex, this slowing is more pronounced. And what is you can see nicely here that although there is a slowing, the temporal occipital lobes, at other regions the brain is working on. So this is a clear sign that this is not a sign of vigilance decay, but you see that the brain in some parts has a slowing, where in others it has not. So this is a so-called focal slowing that we should write in our report in the end. So if you continue with that, and you see that here the slowing also increases and even more, you see these slower activities, these cortices, but otherwise nothing else, no epileptiform activity can be spotted, and we go through that. Okay, so again here now even more pronounced the slowings and slowings. If you see some slowing under hyperventilation that is spreading all over the brain, this is kind of normal. So you know that if you breathe too often, then you get a little bit drowsy because all your acid goes out, and I don't know the English name, the opposite of the acidose you get, and then you can get some generalized slowings. However, if you have like focal slowings, then of course this is some kind of pathology. Okay, so the question for that EEG was if this patient is suitable for ketamine treatment, and we see yes, there's some kind of focal slowing. We would advise that one should do an MRI, for example, to look for any focal things going on in the brain. However, there's no contraindication for ketamine in that patient, and that means he's liable for ketamine. And let me take a look at 1 minute left. Okay. So just let me show you that. So the second EEG I was able to retrieve today, and I just want to show you what we are dealing sometimes with. So this is not a showcase EEG, but a clinical EEG you sometimes see, and you have to deal with that. So I want to show you because this patient, what is going on here? Do you know? So this patient all the time is blinking with his eyes. And there are some techniques and research how you can get rid of them. However, for clinical EEGs, we should not use them because you could disturb original activity. And what you see here all the time, these are the eye blinks, highly disturbing for judging the EEG. However, we see the background activity here, it seems to be fine. And also the desynchronization. Otherwise, the EEG seems normal. However, we have to mark that there are lots of artifacts in this EEG and that it's quite hard to judge. However, as far as we can see, and if we shift to the EEG, there's no signs of epileptiform activity or of any slowings of any kind. Okay, So again, this was this day's meeting. I think there is one correction from Valerio.
Kannst du mich hören? Can you listen? Okay. Is this an angeborener Nystagmus?
No, this is no nystagmus. This is clearly just enabling. If you have nystagmus, it normally should be, let's say, in one direction. So you either have it vertically or horizontally, and this is a clear eye shut. So this is no nystagmus, where just the eyeballs are waving, but this is a real physical of the eyeball. Yes, but this is a good question because the saccades sometimes can be disturbing in the EEG. I don't know if I have an example, but these dipoles of the EEG can also be like artifacts. But this here, what we see is clearly eye closing.
Okay.
Welcome. Any other questions? If this is not the case, thanks for your attention. Remember to solve the quiz. Tobias will be happy if he sees the number rising, and maybe he can also tell us in 3 sessions who will be the winner. Anytime, we are highly competitive here, so don't forget to do the quiz. And I'm happy to see you next time. Thanks, and I wish you all the best for your week. Bye-bye.